So, hi everyone. It's one of those evenings where everyone has connectivity problems, but we will go right ahead with our program. And I'm going to replace Ritu Khanna for a while. We decided a few months ago that there was a lot happening in academics that wasn't getting translated to everyday practice because nobody knew what the other group was doing, and that there was so much in imaging that the practitioner of fertility didn't know, and that there was so much happening in genetics that we would never be able to understand. And so we said, let's put people together and combine it with some of the chapters of the Indian Fertility Society and see what we can produce. And then there was a question of the webinar overload. So we said we have to overcome that. And then that's when I looked at the webinar library that we have and realized that a lot of people were using this as a ready reference for later on and not necessarily being present. But because everybody gets a little message on their cell phones, they know that it's somewhere in the webinar library. So we said, let's go ahead and combine. So today we have the so-called deep dive into polycystic ovarian disease. And let me welcome everybody on behalf of Colonel Pankaj Talwar and Professor Shweta Mittal, and have together here today three groups that are working together. We have, of course, the IFS Special Interest Group for Ultrasound, and we have the Special Interest Group for Genetics, and we also have the Kerala chapter of the Indian Fertility Society. And we're going to try and put together this information. We're going to have three sessions. The first is going to be on whether genetic predisposition matters in polycystic ovaries. And the speaker there is Dr. Sheetal Jindal. The second session will be on the role of ultrasound in predicting response in ovulation induction, a very basic talk that we thought everybody is going to be needing so that we can combine some very basic stuff with some really high-end stuff in the same webinar. And the third speaker will be Dr. Reggie Mohan, and we will hear about managing ovulation induction in resistant polycystic ovaries. So on behalf of Dr. Ratnapuri, Dr. Deepak Modi, Dr. Sheetal Jindal, Dr. Varsha Sampson, Dr. Ritu Khanna, and Dr. Ladbans, Dr. Bharti Jain, Dr. Raju Nair, and Dr. Raji Mohan, we are going to have this program put together. So may I first invite...
Sir, I have a request. I have
yes.
some family commitment, so I would like my lecture to be first. I'd
I
actually
would
already...
like the lecture to be first, which is actually nice because I don't see Ladbans as yet. Okay, so we'll do Dr. Bharti Jain's talk first because she has a commitment. Hi, Ritu, good to see you.
Hello, good evening, sir. I'm so sorry. Yeah. Some network issues. I couldn't make it through it.
Not to worry, we now have you online. So we've changed the order of the speakers. And
yes, sir.
Yes, I've introduced everyone and the groups and the background.
Thank you so much, sir.
Yes.
Dr. Ladbans, madam is there, and I'll just introduce madam for...
no, actually, Dr. Bharti Jain has some commitments, so she wants to start.
Okay.
And right. So if you could introduce Dr. Bharti Jain and the chairpersons of her session, and then we'll carry on with the rest of the sessions. At the moment on the screen, we're looking at a very nice, clear PowerPoint from Dr. Bharti Jain with the pointer working. But if you could please introduce Dr. Bharti Jain and the chairpersons of that session.
Okay, sir, I'll do that. Yeah. And moving to the session, we have Dr. Ladbans Kaur Madam, who is the Director Consultant Radiologist and Fetal Medicine Specialist, Prime Diagnostic Center, Chandigarh. She has a lot of vast experience in fetal diagnostics, high-risk pregnancies, and fetal intervention, with more than 200 talks and deliberations, and of course, got more than 68 publications to her credit. So welcome to you, Dr. Ladbans, Madam. Dr. Reshmi has done a fellowship in reproductive medicine. She is the Senior Consultant Reproductive Medicine, Kinder Women Hospital and Fertility Center at LAP, Kerala, with an interest into high-risk pregnancies, infertility, and of course, she's got a Best Paper Award in Endoscopy ICG 2015. So welcome to you, Dr. Reshmi. And over to you, Dr. Reshmi. If Dr. Ladbans, Madam, has not joined, please introduce Dr. Bharti Jain, Madam. You're there, Reshmi. Over to you.
Thank you, Dr. Ritu. Thank you for giving this opportunity. It's my proud privilege to introduce Dr. Bharti Jain, Madam is a convener SIG Ultrasound IFS from 2024 to 2026. Director, KJ IVF and Laparoscopy Center, Delhi and Faridabad. Madam has been the convener SIG Ultrasound from 2020 to 2022. Madam is a consultant sonologist with more than 20 years of experience. She is an ART consultant at KJ IVF, excellent academician and orator, and has authored many chapters and books. She is heading the charity wing of KJ IVF, which is providing fertility services to poor people. Over to you, madam.
Thank you. Thank you for the kind introduction. Good evening, everyone. It is my proud privilege to welcome you all. As a convener, SIG Ultrasound, I feel thrilled that the current webinar is the joint organization of both the SIG Genetics, IFS Chapter Kerala, and the SIG Group Ultrasound. This is the need of the hour, that amalgamation of many SIG groups should be the thing, because this helps us to widen the horizons, and especially when you are dealing into a topic as controversial as PCO, this is the need of the hour. So today's meeting, as we delve deep into the PCO, dealing with topics, important ones, which are of clinical application, like the genetic aspects of PCO, or monitoring, predicting the response, or planning the stimulation of decreasing in PCO. This, I suppose, every one of you will have a nice meeting, nice take-home messages. And I thank all the chairpersons, the speakers, Dr. Ashok Khurana, and the delegates for sparing the valuable time to be a part of this webinar. So as I start my topic, we know that today ultrasound, with its recent advances, has brought in a major revolution in ART. Other than a diagnostic role, today it is helping to plan the therapeutics, predicting the prognosis. And because of this, it has simplified the protocols. So in my talk today, I will be telling how ultrasound helps us to predict the response of stimulation and thus optimize the control, individualized control ovarian stimulation. I bring greetings from the place where I work, that is KJ IVF. And actually my slides are not moving. I have problem with I have some problem with my slides not moving. Okay, I bring greetings from the place of work.
Click on the screen and then it might move forward. Click once on the screen and then it will move.
Yeah. I think it's see the next slide's on.
Yes.
I bring greetings from the place where I work, KJ IVF Delhi, and today I will be discussing how ultrasound predicts the reproductive endocrinology by demystifying what the ovaries and the uterus are exposed to, and how ultrasound correlates very nicely with the ongoing reproductive endocrinology. So what do the basic ultrasound and the correlates of hormones say? Because of which we can do away with the day-to-day assessment of hormonal analysis and do ultrasound and augment it with Doppler. AMH, which is a time-tested, a new modality to predict the ovarian reserve, correlates very strongly with AFC. FSH, the prime hormone which regulates the follicular growth, can be depicted by seeing the polyfollicular growth. Then in the pre-ovulatory phase, we know that estrogen rises, and adequacy of the estrogen response is reflected by the morphometric changes in the follicle and the endometrium, and Doppler adds on to this. Then comes the luteal phase, where progesterone adequacy is reflected again by the corpus luteum, and the endometrial flows and the Doppler indices are very good prognostic factor in this. But when we have suboptimal factors like a hypoandrogenism, we can see the ultrasound that when you have a high AFC or a high uterine RI, then we are not dealing with good scenarios and we might have difficulty in induction. Similarly, a basal high tonic LH is seen on the ultrasound as an increased stromal echogenicity. And because LH is related to neovascularity, so if you see the stromal vascularity, then it correlates with the high tonic LH, again a detrimental factor in ovarian stimulation. Now, most of the work in ultrasound in ART clinics is done by 2D scans. whether it is planning, monitoring, or prognosticating. But you need a high-end Doppler because we have set values with their thresholds which prognosticate. 3D has got some role, but most of your ART work can be done, and I will be discussing the relevant role of 3D as the topics come. So in my talk today, I will be discussing around the basic ovulatory disturbances, the ovarian reserve, and once we start the stimulation, how do we plan it? We confirm the down regulation, decide the stimulation protocol, change the dose, monitor the, plan the triggering time, and then prognosticate, all of which can be nicely dealt with by ultrasound. So the first basic, the important causes of anovulation, WHO type 1, that is the hypogonadotrophic hypogonadism, and the third WHO type, which is a hypergonadotrophic hyperandrogenism, can be depicted on ultrasound, but to differentiate them on day 2, day 3, we need to do the hormonal analysis. Because the first slide over here is a normal reserve ovary, but the subsequent 2 slides show a low volume and barely discernible follicles. And to differentiate them, in type 1, we have low FSH, LH, and E2. And this difference is important because in type 1, they are amenable to gonadotrophins. But so when we stimulate these ovaries, we find the follicles, but type 3 are resistant to stimulation. And in that, we have to resort to egg donor programs. Then type 2 anovulation, PCO, presents lots of challenges while stimulation. We know that ultrasound, the PCO morphology diagnosed on ultrasound, is one of the criteria to diagnose PCO. The threshold values have set, the ovarian volume has been fixed as 10 cc, but the thresholds of the AFC are changing with time, and they vary with the ethnic variation. There are so many variables, and we have, earlier the threshold was 12, but then it shifted to 20 by the the evidence-based guidelines by the International Society. It was speculated, it was put as 26 by the Androgen XX Society, the International Ultrasound Society of Obs and Gynae. But currently we're following the Rotterdam criteria in which we have set the pattern as 18. But other than diagnosing PCO, ultrasound addresses the functional abnormalities seen in PCO. The hyperandrogenic state, which is responsible for excessive early follicular growth, is seen by an increased follicular growth. Then the high tonic LH is seen by high stromal echogenicity and increased stromal blood flow. Then we know that in PCO, there is an impaired FSH-LH ratio, and this contributes to follicular arrest. An important issue associated with PCO is obesity and insulin resistance. There are studies which say that if we see the follicle size on ultrasound, then we have seen that the smaller follicles, that is less than 5 mm, correlate with the tendency to developing obesity and insulin resistance. And they also signify the AMH dysregulation. So seeing the ovaries on ultrasound holds the key to the available follicular cohort. We can see the recruitable follicles on day 2, day 3. We can assess the sensitivity to the gonadotrophins, and the bioavailability of FSH can be seen by the ovarian sensitive indices. As for the markers of ovarian reserve, we know that they are biometric markers, age, which is most important, and BMI has to be taken into consideration when you decide the dose, because this reflects the bioavailability. Then FSH, LH, they reflect a raised FSH, LH, reflected declining reserve. But when the FSH and LH is raised, then we don't have much therapeutic window available. So the new marker AMH reflects the compromise of ovarian reserve early, and this is being used in most of our cycles as a prognostic indicator of ovarian reserve. Then the 2 ultrasound predictors, that is AFC and the volume, are very good predictors of the ovarian reserve. In fact, when the AMH is low and the patient comes for treatment, then it is the AFC which tells us that the window may be available, however, with a high risk of cancellation. So if the patient wants their own egg, then this window should be used after thorough counseling. Doppler gives a very good role because it predicts the response to stimulation. Peak systolic velocity is the index which predicts the response to stimulation. Now, if we see the two indices, comparison of AMH and AFC, both predicts a compromise reserve. If the AMH is between 0.5 to 1.1 nanogram per ml, or the AFC count is less than 6, then they are poor indicators. And a comparison of the two by one study shows that the AMH and AFC are comparable, reflecting the ovarian reserve. This particular study by Borkhams et al., Boer et al. Said that while predicting a poor and a high response to ovarian stimulation, you can use either AFC or AMH, and these two tests are recommended over other tests. And there is a very strong recommendation about this study. Adding AMH to AFC improves only the prediction of excess response to ovarian stimulation, but it does not predict the poor response. Now, coming to 3D, we know a lot about Sono AFCs. There's a lot of hype about Sono AFC, but this particular study, which compared the manual and automated diameters of the follicle on 3D and 2D, they said that there is no strong evidence that any method is better than the other. And the operator should choose the best method for counting the follicles based on the availability of the resources, skill, and preference. At our center, we are using 2D method to count the AFC because that's easier. Then when we see the follicles, the AFC count makes use of follicles which are of the size 2 to 10 mm. But in this cohort, we have follicles which are 5 to 6 mm and 7 to 9 mm. There have been studies which say that, okay, you count them separately, and follicles of the size 5 to 6 mm best correlates and reflects the two ovarian reserve, but separately measuring them does not give any clinical benefit. Now, once we plan the stimulation protocol on day 2, day 3, what we need to do, we need to confirm that it is a down-regulated cycle, and subsequently we have to monitor the recruitment and the growth so as to we can tailor the dose, or we can plan the trigger and predict whether we have a poor response or we are going in for OHHS. So on day 2, day 3, we require estrogen less than 50 picogram per ml and a progesterone less than 1 nanogram. And on ultrasound, this is nightly reflected by a thin endometrium and no dominant follicle. If we have a dominant follicle, then we know that the estrogen is raised, and we have a corpus luteum, then progesterone is raised. In PCO, day 3 picture, sometimes because of the unopposed estrogen without any progesterone, we find a thick endometrium, and so we need to give progesterone to correct it before proceeding on. Now, Doppler, how does it help in the stimulation? If you see the stromal blood flow at day 2, day 3, it correlates with the follicular response. The mean stromal peak systolic velocity significantly correlates with the follicular response, but the stromal PI does not correlate with the follicular response, and we don't have indices to correlate the two. So this is a paucifollicular response. This is the IUI picture. This is an IVF cycle. We measure from inner to inner, and the normal responding ovaries are the ones in which the stromal blood flow had RI of 0.58 to 0.7, the peak systolic velocity 5 to 10 centimeter per second, and the risk of OHSS, that is the high responders was when the peak systolic velocity was more than 10 centimeter per second, and the poor responders were one when which the peak systolic velocity was less than 5 centimeters. So this helps us to decide whether we have to give the normal dose, or we have to reduce the dose, or to avoid OHSS, or to start with a higher starting dose. Now, we know that follicles are controlled by the changing milieu of the hormones to which the ovary is exposed. So what do the hormonal correlates and the ultrasound tell? We know that follicle of the size 6 mm is FSH independent. When the follicle becomes 6 to 9 mm, it is FSH sensitive, and greater than 9 mm, they are FSH dependent. And follicular action can be, FSH action can be seen when the follicle grows beyond 6 mm. The follicular growth roughly is 2 to 3 mm per day. But if we have a high basal FSH, there is early follicular recruitment, fast growth. And with this, what happens is the cytoplasmic maturity of the ovum lacks the nuclear maturity, and there is an aberration of the endometrial growth. Whereas if we have a low FSH, basal FSH, then there is a slow follicular growth. And this scene is also seen in PCO ovaries. So a slow rise in FSH or LH of inadequate bioactivity suggests an aging ovaries. Now, how to assess the maturity of the follicle on E2? We know that a mature follicle secretes around 200 to 300 picogram of estrogen. So what do we see? The size of the with the maturity of the follicle, what happens? The size is increased to around 18 mm, and with maturity, the RI of the follicle keeps falling. And this increase in perifollicular flow is seen on day 8. And 2 days before ovulation, the RI is lowest, and LH surge occurs with the increase in peak systolic velocity. And this happens 29 hours before and lasts up to 72 hours. So when we have follicle in IUI more than 18 mm, whereas a follicle of even 16 mm in an IVF cycle can be mature. But additionally, you see perifollicular vascularity covering more than 3/4 of the follicular circumference. And you can see the perifollicular flow, which is more than 10 centimeter per second in a mature follicle, and the RI is 0.4 to 0.8. Now, what are the clinical applications of these Doppler parameters? It is not very important in the normal responders, and normally we do not do. But when we have a positive response in poor responders, then we can either do an E2 so that like the number of follicles correlate with the E2 level, or we can do follicular flow and we can combine the two. Now, there have been studies in which the dose prediction has been done, and the predictive dose of gonadotrophins have been predicted, and the factors considered are age, weight, BMI, cycle length, AFC, volume, power Doppler, and the endocrine markers. Other studies have correlated the AFC and the stromal blood flow. Some has used the AFC on 3D volume and 3D stromal parameters to predict the response to stimulation. Now, trigger timing on IUI is when the follicle is more than 80 mm and perifollicular vascularity covering more than 3/4 of the circumference, and perifollicular flow is around the RI of the perifollicular flow is around 0.4 to 0.48 with a peak systolic velocity more than 10 centimeter per second. These are the Doppler pictures of an IUI cycle. Now, time of trigger is another controversial issue because we do not want to end in retrieving immature follicles. Now, there have been insufficient studies in which follicle size was used as a triggering criteria predicting the outcome, but physicians may choose the follicle size upon which final maturation is triggered, and this can be decided on a case-to-case basis as advocated by Chen et al. In a study in 2014. Other factors which decide the time of trigger is the growth of the follicle cohort, the hormonal data on the day of the trigger, the duration of stimulation, and the previous cycle. The GDG does not recommend timing the oocyte maturation triggering on estrogen level alone. And similarly, it doesn't recommend to decide the time of trigger based on estrogen follicle ratio alone. Now, earlier, there were a lot of debates as to whether we should use only TVS or should we add the hormonal parameters. And this study by infertile sterility in 2030 said that ultrasound has simplified the protocols. So we need not add to unnecessary anxiety or cost by combining it with hormonal parameters. And this Cochrane database review by Shiladit Bhattacharya in 2014 also said the same thing, but added that it may be a precautionary good practice to add hormonal analysis in those at a high risk of OHHS. Now, at the end of the stimulation, what you need to evaluate? Clearly, the first index is how many follicles you have obtained. But there is a lot of disadvantage because as a single parameter, it does not correlate with the pregnancy rate or the pregnancy rate. And it doesn't depend on the pre-treatment AFC. So there are a number of ovarian biomarkers which predict the response to stimulation. And I will be discussing these three markers. One is the ovarian sensitivity index, then is the follicle oocyte ratio, and the other is the follicular output ratio. So first, the ovarian sensitivity index. This is the total dose of the gonadotrophins divided by the retrieved oocytes. This predicts the response to stimulation. However, it has the disadvantage that it does not depend on the stimulation protocol. There is no mention of the starting dose or the type of gonadotrophins. Nevertheless, it predicts the clinical pregnancy very clearly. And in case when the sensitivity is low. So those are the cases. They can be explained by receptor polymorphism or the fact that we know there are multiple waves of follicle maturation. But in the current scenario, it can be used, and there are already algorithms which predict the response to stimulation based on this index. And basically, it is an index which is telling for one oocyte how much gonadotrophin dose is required. So this can help you to strategize your dose, and especially when you have a failed cycle. And currently, there have been algorithms which have been developed, especially by AI, which predict the response to stimulation, which predict the the risk of, possibility of having a pregnancy based on this index. Then there are other two indices. One is the follicle to oocyte index, and the third is the follicular output ratio. First, I will be addressing the follicular output ratio. In this, we take the pre-ovulatory follicles versus the AFC ratio. This is an efficient and a quantitative marker of ovarian sensitivity to gonadotrophin. However, the disadvantage is that it doesn't mention the number of oocytes. Ginberg has laid the thresholds of a level less than 0.3 as a low ovarian sensitivity and greater than 0.8 as a high ovarian sensitivity. And we recommended that it should be used in the everyday practice. Now, reverting back to the follicle to oocyte index. This sees the number of the total oocytes collected. It's a ratio between the total number of oocytes collected to the AFCs seen on day 2. So because it is you taking into account two critical indices, both the oocytes which reflect the response to stimulation and AFC which reflect the response. This is a very good index, and it reflects the ongoing dynamics of the follicles on stimulation. So you can see the response. Like if we revert back to the FORT index, how it is helpful. Supposing we have day 2 follicles around 6, and the number of follicles pre-stimulation are 5. This in comparison to a scenario in which the basal AFC was around 10, but the the follicles on trigger was only 5. So if we compare the two scenarios, a patient who had low AFC but manages to have a relatively equal or better AFC. So those are the ovaries which are better sensitive to the gonadotrophins. Now, addressing the FOI index, this study was done on, study was mostly on single embryo transfers, which were done on day 3. And they have seen that it correlated with the clinical pregnancy rate. There was a linear correlation with that. And it also correlated with the number of oocytes. And the thresholds have been put as FOI less than 50 was considered as low sensitivity. And the reason attributed was the genotype or the anthropometric factors or the oxidative stress. Receptor polymorphism also was one of the factors causing this. But the disadvantage was that trigger type may influence the FOI. Now, what are the implications of FOI and FORT in the daily practice? It has been seen that there was this study in which they have correlated the FORT and FOI with the Poseidon criteria. They have seen that these indices were very high. That is, the ovarian sensitivity was very high in Poseidon 3. That is, the young people with compromised ovarian reserve compared to group 1, 2, and 4. So we have a lower ovarian sensitivity in group 2 and 4, and this is attributed to polymorphism and hyperresponse to the gonadotrophin dose. Now, what do we do about it? So we assess the ovarian response sensitivity in the previous cycle, and if we have a poor sensitivity, then we do protocol modification. We can add DHA, we can add CoQ, we can add gonadotrophins, but if there is a normal sensitivity, then we can modulate and increase the starting dose. And this study showed that when the FORT was less than 0.3, even after adjusting the dose and protocol, there was no benefit. Then we suspect receptor polymorphism or genetic mutation, and genetic screening can be added. So predicting OHSS, everyone is very familiar. If we have thin young patients and had OHSS in the previous cycle, there is a high estrogen level more than 300 picogram. Additionally, a steep slope of rise of E2 and a high MH predicts the OHSS. So on day 2, day 3, if we have an AFC count of more than 20, the recent guidelines were more than 20 that predicts a high response of OHSS. So, and a high stromal vascularity, peak systolic velocity, and a preponderance of small and intermediate follicles. Then in these patients, we need to reduce the dose, monitor, and like these are the OHSS situations, and to avoid them, we have to strategize, like plan the coasting, plan freeze-all, change the trigger. And just to conclude, my take-home messages is that ultrasound is a very good tool. It demystifies the reproductive endocrinology, but the scan should be meticulous with a careful interpretation. 2D scans are good, but Doppler, since it has its new dimensions, especially in prognosticating, so we should have a good Doppler. 3D can be useful in select situations, and the future is held by the artificial intelligence. Artificial intelligence, there have been algorithms which have been experimental but successful, and they have predicted the possibility of pregnancy in failed cycles. They have predicted the dose. They have even predicted the time of trigger, but they have used the basic parameters, the hormonal parameters, all the ultrasound parameters. But what benefit we are getting is that we are reducing the number of scans or reducing the number of hormonal analysis. Thank you.
Ladvans, madam. Ladvans, madam. Some network issue with madam. So Reshmi, you can just conclude, and then, yeah, we have Ratna, madam. Reshmi, you can conclude, and then I'll invite.
Right. Thank you, madam. It was a very informative and comprehensive talk, especially your take on FORT and FOI. A few questions, doubts, madam. What is your experience in using of Doppler in predicting the ovarian response? Do you routinely use Doppler in your practice?
We don't use it routinely. We conducted a study in which we studied the PCO ovaries. We tried to see, but what was uniformly applicable was that the stromal vascularization was seen in all PCO patients. However, the indices, we did not find any significant correlation. The study which I showed was a study by Dr. Sonal Panchal, who's done a lot of Doppler work. In my particular study, we did not have threshold parameters with significance. There was a variation, but it did not come out as significant.
Yeah. Thank you. Thank you, Reshmi. Thank you, Bharti, madam, for the fantastic deliberation. And we are always privileged to have with us our mentor, Dr. Ashok Khurana, sir. In spite of his utmost busy schedule, he's always a phone call away. Thank you so much, sir, for being with us. PCOS is not just a fertility issue. Feeling tired all the day, not being able to get a decent night's sleep, and having so many thoughts, anxiety, depression, not feeling a control in your body, needing to get rid of hair every morning, and seeing my hair falling out, not being able to lose weight, feeling so lonely with all of this, and nobody can understand what I'm going through. So today we have something from the genetics to the journey of life of PCOS. And we are privileged today to have the mentor for our IFS SIG group, Dr. Ratnapuri Madam, who is a teacher par excellence, and her vast knowledge and experience is the greatest driving force to us. She is the professor in genetics and chairperson, Institute of Medical Genetics and Genomics, Sir Gangaram Hospital, New Delhi. Dr. I.C. Verma Outstanding Research Award 2019. She is at the panel of experts for WHO Collective Global Network for Rare Diseases. Lot of ongoing research projects in Indian Undiagnosed Disease Program, establishing registry for rare and potentially treatable genetic disorders, more than 140 publications, and so many, many more accolades to her credit. Welcome to you, Ratna Madam, for your blessings.
Thank you very much. And I greatly appreciate and admire this initiative that has been taken, as we said at the initial part, of bringing multiple stakeholders together on one platform to enhance learnings. And I think this is a great way to do it. So all the very best. And thank you for, all of us being a part of it, because I sincerely believe that care of a patient is all multi-speciality and multidisciplinary this current era that we are living in. So thank you so much. And tell us about the genetics of PCOS.
Thank you so much for those enlightening and inspiring words, Madam. And we move to the next session. And for this, I invite our chairpersons, Dr. Deepak Modi, who is a PhD in human genetics, elected fellow of National Academy of Sciences, India, and heads the Molecular Cellular Biology Laboratory. He is the recipient of INSA Young Scientist Award and over 140 publications and current research areas of understanding the mechanisms in embryo implantation and placental development and genetics of sexual development and male infertility. Welcome to you, sir. Dr. Priya Radhakrishnan, who is the consultant Isha Gynecology and Fertility Center, Palakkad. She's very energetic, very hardworking. And so we have got our two dynamic chairpersons. And over to Dr. Deepak Modi, sir, to introduce the speaker and who is a co-convener in their own IFS SIG group, who is Sheetal Jindal.
A very good evening to everyone. At the outset, I thank this entire amalgamation of this ultrasound genetics for this wonderful session. And I'm glad to see genetics getting mainstream. My association with PCOS is as long as my association with genetics, because I started my understanding of genetics with PCOS. And long ago, when PCOS was not even considered as, a mainstream disorder, people were thinking that there's a genetic origin, and most people called us stupid because they thought that it was more of a hormonal problem. And now we understand PCOS can run in families, and we can have people, close relatives having PCOS, and now there's enough evidence being gathered that the different entities of PCOS also have different genotypes. So I'm glad that we have been, genetics has got as a part of mainstream clinical discussions, especially in the context of PCOS. And we have a very fantastic speaker who is also my co-convener of the SIG Applied Genetics, Dr. Sheetal Jindal. I'll request Dr. Priya to introduce Dr. Jindal.
Thank you, Dr. Deepak. Okay,
Yeah.
shall I?
Dr. Priya is there?
Yeah.
Priya, just introduce Dr. Sheetal, please.
Yeah, just excuse me. I just request someone to allow me to share my screen.
1 minute, Sheetal.
Yeah.
You're being introduced and then you'll be allowed.
Yeah, thank you.
Yeah. 1 minute. Yeah. Yes.
Hi, Dr.
Dr. Priya.
Jindal. She's a senior fertility consultant, Jindal IVF Chandigarh, co-convener SIG Applied Genetics, Indian Fertility Society, Treasurer Chandigarh OBG Society, Treasurer Greater Chandigarh Chapter IFS, more than 18 years of experience in infertility, and she has keen interest on infertility in IVF, PGT, and hysteroscopy. And she has written various chapters in books and published papers in reputed journals. Over to you, Dr. Shindar.
Yeah. Please allow Sheetal to share her screen, Karan.
Ma'am, you can share your screen.
Done. Sheetal, done.
No, I can't share my screen.
Karan, you made Sheetal the host?
Yes, ma'am,
Co-host?
already. Yes, ma'am.
Yeah. Yeah.
Are you
no.
able to do it? Yeah. Okay.
Yeah. So is my screen visible to everyone?
Yes, 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 yes.
So at the outset, I thank both the SIGs for giving me this opportunity to talk on this topic. And at the same time, I want to admit that I'm a clinician and not a geneticist, a co-geneticist. So whatever knowledge I have is, I will just share a little bit of my clinical experience along with whatever I gathered from the literature. So I start my talk. The topic given to me was genetic predisposition in PCOS. Yeah. So we all know that PCOS is one of the most common endocrinopathy, which is seen among reproductive age women. This disorder affects women right from her puberty till the age of menopause, in the form of initially abnormal uterine bleeding. Later on, the female can have infertility, and after that, again, it can even progress to endometrial cancer. 1 in 6 women appear to be affected by this disorder, and the prevalence, worldwide prevalence, ranges from 4 to 21%. It can be as high as that. Now, the most important thing is the exact pathogenesis and causative factors are unknown till date. And we all know, but what we all know is that hyperinsulinemia and hyperandrogenism form the basis of the pathophysiology of PCOS. And initially, as Dr. Deepak rightly said, that nobody used to believe that PCOS could have a genetic predisposition, but now we all are quite clear that it has a polygenic predisposition, and it is exacerbated by various environmental factors, especially obesity, and epigenetic factors also play a very, very important role. So now coming to the diagnosis of PCOS, PCOS was initially categorized as a disorder which involved hyperandrogenemia and oligoanovulation, which was initially described by NIH in 1990. However, there was a joint meeting by ISHRE and ASRM in 2003, which involved 3 components as a part and parcel of PCOS, which included hyperandrogenemia, ovulatory dysfunction, and polycystic ovarian morphology. And any of the two criteria, if they were met, then the female was labeled as having being a PCO female. However, this polycystic ovarian morphology has been debated by Androgen Access Society and PCOS in 2006, which said that hyperandrogenemia and ovarian dysfunction, it could be in the form of ovarian dysfunction or polycystic ovarian morphology. So any of both the criteria both the criteria are essential if we want to diagnose the female as PCOS. It was finally the modified Rotterdam criteria, which finally came in 2003, which included all the which required any of the 2 criteria, any 2 criteria out of the 3 to diagnose PCOS, and further defined various phenotypes of PCOS, which I'll be sharing in the next slide. However, it is important to note that you have to exclude non-androgenic causes, which are Cushing syndrome, congenital adrenal hyperplasia, or any adrenal secreting tumors. These have to be ruled out before you label a female as having polycystic ovarian syndrome. Diagnosis of PCOS in adolescents is also very, very important. However, there are a lot of characteristics in adolescents which make it very difficult to diagnose at that early age. Because in adolescents, there is hyperinsulinemia, which starts as the female reaches her puberty. And at that point in time, generally the level of androgens is high in the body. And usually the initial few cycles can be in the form of amenorrhea. And therefore, the diagnosis of PCO in adolescence can be quite tricky. So you have to, oligoamenorrhea can only be diagnosed if there is primary amenorrhea by the age of 16 years, female does not get her menses, or she is having oligo or amenorrhea for at least 2 years. So now coming to the PCOS phenotypes. There are 4 main phenotypes of PCOS which have been diagnosed. First is phenotype, and it includes the features of polycystic ovarian morphology, hyperandrogenemia, and ovulatory dysfunction. So if all the 3 phenotypes are present, then it is labeled as phenotype A, and it encompasses 2/3 of all the phenotypes. This is the most common one which we see, followed by phenotype V, which includes hyperandrogenemia and ovulatory dysfunction. The third phenotype is phenotype C, in which there is the main component is hyperandrogenemia and polycystic ovarian morphology on the ultrasound. This is the phenotype in which it is an ovulatory PCO, so problems of infertility are seen at the minimum in this phenotype. And the last phenotype is ovulatory dysfunction associated with polycystic ovarian morphology on ultrasound. This phenotype is slightly on the controversial side. Some people say that this phenotype exists and some say it does not. Now, what has been proposed is that all these different phenotypes are the result of different genetic pathways getting activated and leading to one particular type of PCO. So now coming to the basic pathophysiology, I just want to quote here Frank's hypothesis, which states that in a genetically predisposed female, there is excess androgen production by fetal ovary in response to maternal HCG. And placenta of these females is not able to aromatize these androgens. So that is why at birth, these females do have some sort of androgen excess in their body in the form of testosterone. At puberty, when the hypothalamo-pituitary ovarian axis is getting activated, there is physiological hyperinsulinemia, which triggers hyperandrogenism in these females. So hyperandrogenism forms the basic crux of problem in PCOS, and associated with insulin resistance leads to various clinical features and clinical metabolic features of PCOS, which we see in the form of hirsutism or acne. And as far as reproduction is concerned, there is oligoanovulation, menstrual irregularity, and subfertility. And because of insulin resistance, these females are at risk of developing type 2 diabetes mellitus and increased cardiovascular risk factors. These females, because of their differential fat deposition in the body, do have problems of depression, anxiety, and low self-esteem due to their different body image. Now, before I embark onto the genetic predisposition in PCO, I just want to share one interesting case which I encountered in my OPD. This female was Mrs. S, 33 years old, and she was PCO phenotype D. She had PCO morphology on ultrasound, and along with that, she had ovulatory dysfunction. She used to be amenorrheic for a period of approximately 6 to 8 months. 6 to 8 months in a year. I mean, not even having at least 2 menses in a year, and there was no hirsutism which was there. And when I did a scan for her, the endometrial thickness was very, very high with a lot of vascularity. So I did a hysteroscopy for her, and she was diagnosed to have well-differentiated adenocarcinoma of the uterus. And she was very keen to have a pregnancy. And when I had put her on, I inserted a Mirena, and medroxyprogesterone acetate was given to her for a period of approximately 1 year. She was very keen on her pregnancy because she was having a very big social issue with her husband, who was after her life because she was not able to give a baby to him. So anyways, finally, during this course, she got divorced, got remarried, and again came to me. And again, I biopsied her. Her adenocarcinoma had reversed. And after that, I did IVF with self-X with her. Throughout the pregnancy, she was severely diabetic, developed severe preeclampsia at the age of 25 weeks, and then this pregnancy ended in an abortion. So now this was a very severe phenotype of PCO, which I am discussing. And the interesting thing was her real sister was also a PCO. She's also coming to me, and she also conceived through IVF and now is approximately 32 weeks pregnant, but she was hirsute. The female, the proband, however, did not had developed uterine cancer and was absolutely non-hirsute. Further, when I marked the 3-generation pedigree, her mother also had suffered from infertility and had conceived spontaneously, however, after 8 years of her marriage, and her nanny had also died of uterine cancer. So this case very clearly shows that there is some sort of genetic predisposition, and I'm sure all of us would have seen such type of females, encountered such type of genetic histories in PCO females. So this brings me, so this case also very clearly tells us, yes, there is a familial transmission of PCOS. The first genetic basis was described by Cooper et al. Way back in 1970s. And initially it was thought that PCO has an autosomal dominant mode of inheritance and that it is a single gene disorder. But then subsequently, as more and more studies were done on the genetic basis of PCO, it is now said that it is polygenic, and at least 50 to 60% of features are seen in the first degree relatives of the probands. There is a lot of phenotypic heterogeneity which is seen in different siblings, as we saw in this case also. So they might have had genetic risk factors inherited, which is being passed down from generation to generation, but they do not share all the traits of PCOS. Means someone will have oligoanovulation as a prime symptom, and the other one might have hirsutism as the prime symptom. So anyways, genetic studies have shown in twins that there is a 72% correlation of features in monozygotic twins and 38% in dizygotic, meaning which further supports this fact that PCO has a familial transmission. Now, there have been genome-wide association studies which have been conducted in PCOS, and it has been mainly done in Chinese and European women. And this genome-wide association studies have helped us in identifying various loci which are associated, which confer the female the risk of PCOS. And these are the, and some of them have been found common in the Chinese women as well as the European women. The current study which I'm showing was a case control study in which there were more than 10,000 females who were diagnosed to be PCO, and they were compared with the controls, more than 1 lakh controls. And these are the various loci on different chromosomes which were found to be associated with PCO. And it has been found that genetic architecture. So the results of these studies have shown that isolation of all the PCOS subtypes is possible. But the interesting thing which they found was that even if the PCO phenotypes are different, but the genetic architecture is similar across various diagnostic subtypes. And if we identify the function of these, however, it has been difficult to find out the function of these variants, genetic variants, through these studies, because many of them are residing inside introns or in between the genes. So these the most common variants which have been identified as an example is FSH beta. Now the females in which this if there has been any variant found in this gene, it confers the risk of PCOS to the female, and usually the females will end up having high LH levels and lower FSH levels. Another intron which has been found out is DEN and DI, and this also has a locus which has been implicated in hyperandrogenism. So using these GWAS studies and electronic medical record, maybe in the future, there is a possibility of isolating all the subtypes of PCOS. So now there is a statistical analysis which is called as Mendelian randomization, and this has been used. This is a very interesting concept in which people have tried to establish a genetic causal relationship between obesity and PCOS. So various genetic determinants for traits like BMI, fasting insulin, depression, male pattern baldness, all these genetic determinants have been increasingly found in PCOS females. In fact, it is said that most of the PCO females carry genetic determinants for traits like BMI, for traits like depression, meaning that PCO females will have these problems quite often, and as we see clinically also. Obesity is also found to be very commonly, the variants associated with obesity have been also very commonly found in PCO females, and vice versa also is also true. So where do all these studies lead us? So all these GWAS studies which have been done till now, they tell us the proportion of genetic risk which each variant will carry, and we can calculate the polygenic risk score out of these GWAS studies. And it is possible that each variant which is identified by these studies, it can be weighed against the relative influence of that variant on that disease. This risk score can help the clinician in predicting the risk of PCOS before the onset of disease, and they can intervene early. But the issue is that currently the genetic risk score, the polygenic risk score, has not reached sufficient diagnostic ability, so that it can be used in the clinical practice. Now, so I think the future of PCOS is going to lie in this precision medicine. It will be possible to get to have that polygenic risk score, and precision medicine will break down PCOS into different subsets depending on the disease risk which we calculate by the polygenic risk score, and we will be able to stratify the risk and individualize treatment in most of the PCOS cases. For example, I just mentioned the FSH beta locus. So it could be a gonadotropin etiology, and in case there is some variation found in this locus, we know that it will lead to hypersecretion of LH and altered response once we are stimulating the females. So if we are able to establish individual risk score for every female, it is definitely possible that we can intervene in such patients maybe in a different way. These are the few genetic loci which have also been identified, like ERBB4, YAP1, and ZBTB16 loci, and they have been associated with ovulatory dysfunction in PCO morphology. So the question which was given to me was, does genetic predisposition in PCO matter? Yes, definitely it matters. PCO does have genetic predisposition, and probably in the future we will be able to give an additional individual polygenic risk score to the patient, and maybe the treatments will be tailor-made according to the patient's individual risk. But currently this clinical application is not elucidated. So currently what we are following is the standard practice that hyperandrogenemia and hyperinsulinemia form the crux of any PCO pathology, and accordingly, whatever studies have been done, accordingly, we are treating the patients in the usual fashion. So to conclude, I want to say that genetic architecture is similar across all PCO diagnostic categories. The next genome-wide association analysis will incorporate large genotype datasets, which can be linked to medical records, and it can help us in increasing the numbers and incorporate additional ethnic subsets. Today, we have we have studies mainly in Chinese and European women. And the resulting genetic loci can then be used to create genetic risk scores to identify PCOS before the onset. So, which means that if we know, if we are able to give a genetic score to a female before she turns adolescent, then there is a likely chance that she can do a lot of lifestyle modifications, and maybe we are able to prevent a lot of problems which this female will encounter later on in life. So this genetic data can then be incorporated with clinical information, environmental and lifestyle data for precision medicine approach to PCOS diagnosis and treatment. So thank you very much.
Thank you, Dr. Sheetal, for really nicely summarizing all the studies on PCOS and genetics. I understand it's extremely difficult topic because terms like GWAS and associations, risk factor are sometimes many of our people will be even hearing for the first time. But it is very interesting to know that PCOS is a genetic origin. Very nicely was put up by you that if we know the risk of PCOS through genetics, we know that these patients will have to be managed very differently. You know, often clinical conditions, we call them as resistant PCOS, you know, which upon multiple treatments, which don't respond. So do you think that these resistant PCOS would have a stronger genetic nature as compared to the others which respond to treatment?
Probably.
So this would be one exciting thing to study.
So resistant PCO at this point in time, how do we call resistance? What do we call resistance? We call it gonadotropin resistance. Now we do not know if we know that these genetic loci are responsible for causing the gonadotropin resistance in these females. Maybe we can have different alternative therapies or alternative methods to to stimulate them, or maybe it is just hypersecretion of LH which causes gonadotropin resistance. We don't have answers to these questions at this point in time.
Absolutely.
That is why I found this precision medicine. I know it's a long way because, I mean, you people are geneticists, you people would know much more than me, but this is what I could summarize out of what all I read. But then definitely we see a lot of PCOS in families. And it appears to me that obesity and PCO has a very strong genetic link. We all know that. And lifestyle factors is something the final treatment at this point in time is clear that it has to be only lifestyle factors, which if we modify, will. But then when we diagnose PCO, that time it is very late. So there is, I mean, and I think the train is already gone. So what is more important is prevention, and probably genetic basis can just guide us as to if we can prevent it.
Absolutely. So detected way early before a very strong clinical phenotype, it would have a very different management protocol. But my colleague, Dr. Shabani Mukherjee at the Institute, has spent really last 15 years understanding genetic basis of PCOS. And she's published a series of papers. And based on the data, she suggests that there are certain genetic loci which predispose a woman to obesity, and certain genetic loci predispose a woman to insulin resistance, hyperendolia. So the problem is that our genetic makeup in India is very different from that in the West, and there's very little Indian data coming, except for Shabani's group. I've not even seen much data coming from the rest of the country. So I think it's time as clinicians and as geneticists and researchers, we all come together and probably, make this picture a little more clearer so that the genetics can get to mainstream practice, and by the end of it, we help women with PCOS.
Yeah, maybe. So we have a registry, IVF registry now, and it is open, at least in Chandigarh, it has started working. It's a national registry. So if we have the diagnosis and, maybe if we have the data across India, maybe it will help. Yeah.
Sure.
Yeah.
Great. Thank you so much.
Thank you.
Thank you, Sheetal. That was a very nice, presentation. I think so many factors: environment, nutrition, then you go on to genetics, and yet we have to keep diving, I think, more and more into PCOS. And Deepak sir will be having one of your next, insights to go more deeper into genetics with our sessions, and the follistatin gene, and so many things still to be, taken up and found. I think we'll locate every gene for obesity, for this and everything, and we'll be able to hit on those levels. And
it is going to be the future of medicine for sure.
So it's very interesting, but it's very interesting that still we can move to locate those things also. So thank you so much, Sheetal and Dr. Deepak and Dr. Priya, for this insights, into this genetics. And we were so lucky to have you all with us for this webinar. So moving on to the session 3, we call upon the chairpersons, Dr. Shamima, who is a senior consultant, Esther Women Health and Fertility, MedCity, Cochin. She is interested into laparoscopy and she is a robotic surgeon as well. Trainer for perinatal mental health course by AICC RCOG South Zone, presented papers at national and international conferences and published 10 articles in the indexed journals. Welcome, Dr. Shamima. Dr. Jaya Lakshmi Suraj, who is the organizing secretary of AKCOG 2019. She is the director of Dream Flower IVF Center, Kasaragod, and she's a recipient of ESAD Eminent Achiever Award with expertise into recurrent IVF and recurrent failures, IVF failures, and laparoscopy, poor ovarian reserves, endometriosis, and male infertility. Welcome to you, Dr. Jayalakshmi. And I would like you to invite Dr. Reggie Mohan for his presentation. Dr. Shamima, can you introduce Dr. Reggie?
Sure. It's can I see the slide, please, of Reggie's CV slide, please?
Yeah, she wants a CV slide. Yes.
No, actually,
yes.
It's a great pleasure to introduce Dr. Reggie, who is a friend and classmate of mine. So he is an additional professor in Department of Reproductive Medicine and Surgery in Government Medical College, Thiruvananthapuram. And he has also he's also the chairperson for Reproductive Medicine Committee, Kerala Federation of Obstetrics and Gynecology, and state coordinator for Food and Drugs Committee, FOGSI. And he was a former chairperson of Academic Committee of Kerala Federation of Obstetrics and Gynecology and an editor, former editor of KFOG Journal. Welcome, Dr. Reggie. And I think this topic is a very much, it's a need of, everyday practice. We need to know about these things. So I think Reggie will be going to enlighten us on this.
Thank you, Dr. Shamima. I'll like to share my slide. Good evening, everyone. Thank you, Ritu Madam, for the opportunity. And sorry. Just looking for my. Can you see my slides?
Yes, sir. We can see. Dr. Reggie, we can see the slide. You can move the slide now.
We can see. Reggie can put it in the slideshow.
Yeah. Can you see now?
Yes, we can see.
Is it in the slideshow mode?
No, it's not in the slideshow mode.
Is it okay?
Now it's in the slideshow.
Yeah.
Okay.
Now.
So thank you, Dr. Shamima, for the kind introduction. Good evening, chairpersons, Dr. Jaya Lakshmi and Shamima. Thank you, Ritu Madam, for the opportunity. Thank you, Pankaj Selva sir, Ritu Madam, Raju, all for this wonderful opportunity to share a few moments with you regarding the management of ovulation induction resistance in polycystic ovarian disease. So I'll be outlining my talk on the polycystic ovarian disease diagnosis. Part of the talk was been covered by my previous speakers, Dr. Sheetal and the madam, Rekna madam. So I'll be talking briefly about the management of anovulatory infertility, then coming into the resistant anovulation and tackling how to tackle this resistant anovulation. So as already told that the burden is rising day by day, you know, the prevalence is almost 5 to 15%, and 1 in 10% women face PCOS from the menarche to the menopause. And in India, the amount is around 36%, and it is very much prevalent, especially in the infertile woman, that ranges from 15 to 20%. And definitely this PCOS is going to affect the quality of life. And you know the long-term health implications, like health complications like type 2 diabetes, hypertension, endometrial carcinoma, all those things. And you know, very whopping $88 billion are there to diagnose this polycystic ovarian disease. This is way back in 2020. So that is very much more nowadays. So my presentations will be basically loosely based on the recent guidelines, that is 2018 International Evidence-Based Guidelines by Teed et al. And the 2023 guidelines published by Monash, Tripos, ASRM and the HRA Society. So basically the diagnostic algorithm of PCOS by the Monash University 2023 guidelines is basically you have to look for the irregular cycles as well as clinical hyperandrogenisms. And if there is no clinical hyperandrogenisms, you have to go for a testing for biochemical androgenism. And if only irregular cycles are there, that is the step 3 or hyperandrogenism. So you have to keep in mind that in adolescents, ultrasound is not needed for diagnosis. That is what we mostly face. We see in our OPD most of the adolescents and the young girls coming with the diagnosis of PCOS and all. And what you have to remember is in adolescents, ultrasound is not indicated to diagnose PCO morphology. So always you have to think of other causes like an elevated or deranged thyroid, TSH, or prolactin, especially when there is an irregular cycles. So the way old Rotterdam criteria, that is the 3 components, that is oligoanovulation, hyperandrogenism, and polycystic ovarian morphology is there to diagnose PCO. 2 out of 3 criteria is needed to diagnose the polycystic ovarian syndrome. And of course, you have to rule out other causes of hyperandrogenism. So already, Sheetal madam has already told that there are 4 different types of PCOS. That is phenotype 1, which is the classical one. Phenotype 2, which is the hyperandrogenic anovulation, where there is only hyperandrogenism and oligo or anovulation. And type 3 is the ovulatory PCOS, where the ovulation is happening and you got only a hyperandrogenism as well as a polycystic ovarian ultrasound. And the phenotype 4 is the non-hyperandrogenic PCOS, where there is no hyperandrogenism, only oligoanovulation and a polycystic ovary. So you have to know what is anovulation or oligoanovulation before the diagnosis. According to the criteria or the evidence-based guidelines, in the first year, it's to have a irregular menses is normal, and from 1 to 3 years post-menarche, the period can go from 21 days to 45 days. Then after 3 years of menarche or just near to perimenopause, the cycle should range between 21 to 35 days or less than 8 cycles per year. Then 1 year after post-menarche, any cycle which is more than 90 days can be labeled as oligoanovulation or oligo-ovulation or anovulation. Then first year of post-menarche, again, more than 90 days of any one cycle can also be labeled as anovulation or ovulation. Of course, primary amenorrhea and yes. So the basic algorithm is first you have to diagnose polycystic ovarian syndrome, and basically the problem with us or the infertility people is the anovulation to correct. So the first line management is always to correct the preconceptional health and lifestyle. That is the prenatal factors you have to correct. And first line of medical management is, of course, your oral ovulogens like letrozole or clomipene citrate, which I will be talking in the further slides. Then the second line of medical management is the drop-ins or the laparoscopic drilling. And the final or the third line of management is, of course, our in vitro fertilization. So the options are like this. You have to go for the prenatal factor correction. Then there is aromatase inhibitors, clomipene citrate, insulin lowering medications and adjuvants, gonadotropins, laparoscopic ovarian drilling, as well as finally the ART. So the most important thing, as madam has already told, that if suppose if there is a genetic predisposition and all, what ignites or what increases the risk of polycystic ovary syndrome is the lifestyle. So lifestyle interventions and management is the best thing or the best part to curb this disease. So in lifestyle intervention, the main thing is the exercise or a multi-component diet with exercise and behavioral strategies. So this should aim at improving the metabolic health, including the central adiposity and the lipid profile. The main culprit is the central adiposity, which is increasing the central as well as the peripheral adiposity, which is increasing the estrogen and androgen levels. So to optimize general health, the quality of life, body composition, as well as weight management, lifestyle management is very, very. So even with a small weight loss, or even in the absence of weight loss, regular exercises, you can see the improvement in the clinical parameters of a PCOS. So the goals should be tailored according to the energy deficit, according to the individual's energy requirements, body weight, as well as the physical activity level. So again, you have to focus on the central adiposity as well as the metabolic health, and always you have to give them proper support, and you have to have a regular periodic assessment of this exercise and the weight reduction. So always the goal should be SMART, that is, it should be specific, measurable, achievable, realistic, and timely. And you have to give them constant support, engagement, retention, adherence. Always what people will do is you start exercise, go to gym, go for 1 month, then stop, you'll have a rebound weight gain. So adherence is very important. Maintenance of the goals is very important. And that will in turn increase or improve the health outcomes with PCOS. So what you can see is, you can see the obesity prevalence is almost up to 65%. And these people are again prone to have an ovulation. And just see, several papers are there, but just with the 5% body loss or body weight loss in obese women can translate into an improved reproductive outcome by improving the hyperandrogenism, and the features like hirsutism improves, the menstrual cyclicity comes back to normal, fertility comes back to normal, even with a very slight, that is 5% reduction in the and again the insulin resistance, again it also will improve your. So basically, this weight loss is primarily aimed to reduce the hyperinsulinemia, increase the insulin sensitivity, as well as it will restore the ovulatory cycles. Again, sporadic ovulation is, of course, seen as you would have practicing for so many years and all. You can see with a moderate weight loss, you can see so many people are getting or regaining the sporadic ovulation. The best example is my kid, who was a bit obese and all, went to hostel, had hostel food, she had normal ovulation. So no, she's having normal periods. So again, obesity, as you know, that it's associated with poor obstetric outcomes and all. So the weight loss is very much important. So dietary interventions, again, there is no specific diet which tells that this diet should be followed to reduce the weight loss at all. Any diet composition is fine, which is inconsistent with your guidelines. Again, it should be flexible and according to the food preferences. So many diets are there, like Mediterranean diet, keto diet, DASH, GI diet, protein-based diet, all those things. But again, studies have shown that there is still a lack of sufficient data to support a specific diet for long-term efficacy, safety, and health. Definitely, dieting is needed, which should be tailored. So exercise, as all of you know, that how the exercise, again, a particular exercise is not, again, have proven that it has improved the ovulation outcome and all. But some physical activity is better than none. And always limit the amount of being sedentary sitting, reduce the screen time, that is very important. So you need to have 150 to 300 minutes of moderate intensity activity, or 75 to 150 minutes of vigorous activity for the ideal, that is what is promoted. Again, 250 minutes of per week of moderate intensity activity, or again for adult, 250 minutes per week. That means hardly it comes around 40 to 50 minutes per day. So that's not a big time. So if you do exercise, or definitely for 30 to 40 minutes per day, definitely it's going to help you in weight reduction as well as improving your androgenic parameters. So basically, you almost all will be having the fitness tracking devices, either a watch, mobile, or a smartwatch, or a smartphone, which can which allow your calorie count, step count, all those things, and the exercise intensity and all. You can make use of your fitness tracking devices. Again, it should be lifelong health strategies, and always form realistic, tailored lifestyle goals. And nowadays, again, there is a stigma, and always the guidelines of showing that even before weighing a patient, you have to ask the permission whether I can weigh you, or because it is emotionally traumatic to tell them that you are obese or you are overweight or something like that. Always you have to get the first support from the family. So always you have to get counsel and educate the family also regarding the importance of weight gain. So coming to the topic proper, that is the oral ovulogins. In our armamentarium, the first shot is always letrozole, that is aromatase inhibitors. Two types of aromatase inhibitors are used. That is mainly the first thing is the letrozole and anastrozole. You know, letrozole acts by aromatase inhibitors, and there is no estrogenic negative feedback on the hypothalamo-pituitary axis, which causes an increase in the FSH and which causes a monofollicular development. So ideally, the dose to be started is 2.5. It can increase up to 7.5 milligram per day, and usually given from 3rd to 7th day. Usual adverse effects includes GI disturbances, asthenia, hot flushes because of the hypoestrogenism, headache, and back pain. So these are the standard regimes. That is that I will be coming into the details in the later slides. You can see higher doses up to 7.5 or a single dose of 20 milligram per day in the day 3 of cycles, or an extended letrozole regime. Stair-step protocols. These are the various letrozole regimes used for ovulation induction in PCOS. So that's how you start. That is from the day 1 for 5 days. Then you monitor, you trigger with HCG, and depending upon your method of intervention, either timed intervals or an IUA can be done. So regarding letrozole efficacy, the Frank et al. Cochrane review in 2014, it has definitely shown that it has got a better pregnancy rate, live birth rate when compared to clomiphene, and even a better ovulation and pregnancy rate when compared with the laparoscopic ovarian drainage. So Wang et al. Has got a famous network meta-analysis published in 2017, so which showed that ovulation rate is almost 86%, almost at par with the gonadotropins, which has got an 88%. So CC with metformin has got a 75% ovulation rate. Clomiphene has got only 51% of ovulation rate. Just see the next slide, that is the live births comparison. Here, you can see the live birth of letrozole in Wang et al.'s meta-analysis. It's almost 81% when compared to FSH and CC. It's far ahead of CC. That is, CC has got only a 36% of live birth rate, but letrozole you got 81% of live birth rate. Just see the multiple pregnancy rate. You can see a very much increased multiple pregnancy rate with both FSH and clomiphene, but you don't want multiple pregnancies in this era of increased NICU admissions and increased cost. So you want a single pregnancy. So you see the multiple pregnancies rate is also very less with letrozole. So suppose with your conventional dose of letrozole, if it is not responding, if the PCOS zone is not responding, always think again and rule out the endocrinopathies like hypothyroidism. Once again, you go back to your routine. Think of hypothyroidism, think of hyperprolactinemia, think of any other exotism producing etiologies, relaxation producing etiologies, any ovarian insufficiencies there. Go for an FSH, LH, or an AMH. And in obese women, always do a GTT. So you have to think of letrozole resistance when the letrozole in the normal dosage is low. So to conclude, that is the letrozole should be the first line pharmacological management for ovulation induction in an ovulatory woman with PCOS with no other infertility factors. So they compared lansoprazole and letrozole. What the Frank et al. Has found in the Cochrane review is there is no difference in the clinical pregnancy rate. As all of you know that lansoprazole starts with 1 milligram per day for 5 days. In some cases, you can try lansoprazole, but the efficacy of there is no difference in clinical pregnancy rate when compared to letrozole. Coming to the SERMs, that is another group of subset of patients. Again, clomiphene was our main drug long before. It was discovered by Greenblatt, 1961. Clomiphene and tamoxifen are the two common SERMs used. So you can see it is a selective estrogen receptor modulator, which has got both estrogenic as well as anti-estrogenic properties, which is the main problem with the clomiphene citrate. So you can see the normal regimes is usually again day to day 5, day 2 to day 5. You start with 50 milligram. You can have empirical incremental titration. The FDA approved maximum dose is around 100 milligram per day. Sometimes we may go up to 150, but I always go up to 100 milligram per day. And beyond 6 cycles is not desired, in this case undesirable. And you can see the percentage of ovulation. You can see with 50 milligram, almost 52% ovulate. With 100 milligram, another 22% may ovulate. As you increase the dose of clomiphene citrate, the rate of ovulation comes down, down, down. So best thing is either with 50 or with 100 milligram. So again, you can see from this slide that is our Roy homework in 2005 published in HR. You can see this still strong. So it has got an ovulation rate of 73%, but the clinical pregnancy is only 36, almost half only is the clinical pregnancy rate. And there is increased risk of multiple pregnancy, miscarriage, and all those things with clomiphene citrate. And why this happens, because of the anti-estrogenic side effects of clomiphene, that is, it has got a bad effect on the endometrium. It thins out the endometrium as well as gets the cervical mucus, and it can cause high LH also. Again, this is the evidence-based guidelines, that is clomiphene citrate plus metformin is better when compared to clomiphene citrate. Common side effects, again, mood swings, hot flashes, visual disturbances, breast tenderness, and all these things. And always you have to remember two terminologies, that is clomiphene resistance and clomiphene failure. There is no ovulation with maximum dose of clomiphene citrate. It is called clomiphene resistance. And clomiphene failure is no conception within 3 to 6 cycles, ovulatory cycles of CC. So when there is a clomiphene citrate resistance, you have to think of risk factors like obesity, older age, increased serum androgen levels, and insulin resistance. So all these risk factors can cause clomiphene resistance. So the options when this was time tested and it was well evaluated, there are different options. Whenever you see a clomiphene resistance option, you have to switch over to either you have to extended clomiphene citrate, but again, that is not advocated because of the side effects. Then you can add on HCG towards the end. Additional dexamethasone is another option. Additional bromocriptine. Go with the pre-treatment suppression, that is, you give 1 or 2 cycles of OCP suppress, then start on clomiphene. Sometimes improve the ovulation rate. You can add on insulin sensitizing agents like metformin to increase the ovulation rate. Definitely, you can add gonadotropins. You can have a sequential clomiphene plus gonadotropin, that is either you can FSH or an HMG. Day 6, day 7, day 8, and in a continuous manner. Again, you have to advise them aggressive weight loss regimes, and of course, you can go for an laparoscopic ovarian removal. So coming to again another option for from SERM is you see that is the tamoxifen, which can be given 20 to 40 milligram can be given from day to day 7. So again, this study by Brown et al. Published in 2016, you can see there was no difference in live birth rate, miscarriage rate, or rate of ulcers when compared to clomiphene and tamoxifen. Always you can take it as a second option whenever there's resistance or your patient is not getting pregnancy. You can think of tamoxifen, but again, some countries it's an off-label. So this is again the RCT by Legro et al. Published in NEG in 2014. You can see compared the letrozole and clomiphene, you can see that the ovulation rate is significantly higher with letrozole. The cumulative live birth is significantly high with letrozole. Pregnancy loss is almost similar. Single pregnancy again very high with letrozole. Major congenital anomalies. Again, that was one of the reasons why letrozole was banned way back and all. But later the study showed that the major congenital anomalies were not much of difference between CC and so. So this is the Cochrane database published in 2022, which compared both letrozole and clomiphene, and definitely letrozole had an upper hand. It appears to improve the live birth rate as well as pregnancy rate in an ovulatory PCOS compared to SERMs and all. Okay. And again, the ulcers risk was also reduced with letrozole. And again, there was high certainty evidence for no difference in miscarriage rate and pregnancy. So that is the final thing. That is the 2023 international guidelines. Again, letrozole is the first-line pharmacological management of the ovulation protection. So let's see why there is resistance to oral medications. See, we already saw about the clomiphene resistance. So we will be talking about letrozole resistance. So you can see in this interesting study by Wu et al. Published in BMC in 2023, they found out there are some predictors of response to ovulation induction using letrozole with polycystic ovarian syndrome. To summarize their findings, they found out that the cumulative ovulation rates were significantly lower in patients with late menarche, that is, if the menarche happened after 13.5 years, or if the LH ratio was more than 1.80, or there's a high AMS, that is more than 9.78, and if the free androgen index is more than 5.99, all these patients had a less cumulative ovulation rate. So there is something called letrozole resistance. Almost 15% may fail to ovulate with your conventional dose of letrozole. So what are the different options? Although you know that CC resistance have been studied widely, but this letrozole resistance, you see only very few papers. So what are the options? You can have add-ons, you can have different regimes of letrozole, and you can go on for gonadotropin therapy or the laparoscopic treatment. So this is again another good paper published by Sujoy Dasgupta in Eshrei, Amsterdam. So what he found out, but even with 10 milligram per day of letrozole, around 2.7 per woman did not eat. And when he subjected those women to CC, again 38% women ovulated, and 24 women ovulated with gonadotropin. So if you think of any other regimes, suppose if there is letrozole resistance, you can think of CC, you can think of gonadotropin. So what his paper conveyed is correct identification of letrozole resistance and choose an appropriate subsequent method to treat these couples. So what are the different options whenever you see letrozole resistance? Other than gonadotropin, other than jumping into the laparoscopic ovarian drilling or gonadotropin, what are the different methods available? So you can go for extended letrozole regime, you can stair-step regime, you can go for a step-up regime, you can add on clomiphene with letrozole, you can add adjuvants like dexamethasone, metformin, all those things. Another option is sequential regime with the gonadotropin. So we'll go one by one. So what is extended protocol of letrozole? That is, you give 10 days of 2.5 to 5 milligram from day 1 to 10, and you assess. So definitely higher pregnancy rate, multifollicular ovulation. That is one problem with this extended protocol. Give better endometrial thickness was there again with letrozole, extended letrozole protocol, especially in CC resistant PCOS and letrozole resistant PCOS. Extended protocol is an option. So this is a study published by Badawi, and he found that this long letrozole protocol can produce more mature follicles and subsequently more pregnancies than the short or 5-day letrozole therapy. So this is again another paper published in 2023 for sterility by Zion. This is Su et al. From China. Again, he also found that the longer dosage, again, if the letrozole, if the woman is not responding to your normal 5 days or 7 days, definitely you can go for an extended letrozole protocol, and it is a feasible method of ovulation induction in women with PCOS and with letrozole resistance. So again, the same guy, that is Joy Dasgupta. So whether this extended letrozole regime, can it be applied to all? So that again, another fantastic paper. This is a prospective randomized controlled trial published again from China. It's a recent paper from 2024. That is again, he applied for all. The question was whether the extended letrozole, which is supposed to be better than the short letrozole protocol, can it be applied to all patients of PCOS? Again, what he found was, again, a change from standard strategy of ovulation induction is not advisable. So you cannot extrapolate the extended letrozole regime to all patients, because again, further studies have to be there. And again, this extended letrozole is supposed to be supposed to be good for a specific population who fail to respond to your conventional regime or your CC resistance. So for extended, suppose if you're going for an extended letrozole protocol, it should be for a specific population of failed letrozole or CC resistance. So Coming to the next protocol, that is step-up protocol. What you do is on day 2, you give 2.5 milligram. Day 3, you give 5 milligram. Day 4, you give 7.5 milligram. And day 5, you give 10 milligram. So this is another protocol in CC resistant PCOS or letrozole resistant PCOS. Again, studies have found that there is an increase in the pregnancy rate. But again, the problem is multiple follicular ovulation, twin pregnancy, and all these things. Another protocol is sequential protocol. They usually follow, that is 5 days of letrozole followed by either HMG or pure FSH or recombinant FSH for next 3 days and do a follicular tracking. Definitely you can see monofollicular development. Sometimes you may get multifollicular development also with sequential protocol. So coming to the most important thing which is on the rise is the stair-step protocol of letrozole. So what happens here is you start the stair-step protocol. You start those with 2.5 milligram for 5 days, and from either a spontaneous menses or a progesterone-induced withdrawal bleeding. You do a scan on 10th day, and if there is no follicle, definitely you shouldn't wait for the progesterone withdrawal or for the hormone periods. So what they tell is you can increase the dose of progesterone. Suppose if you start with 2.5 milligram of letrozole from day 2 to day 7, there is no follicular growth on day 10 or day 14, you increase the letrozole dose. Okay, so increase the dose to 5 milligram or double dose. If you are giving 2.5 milligram BD, you increase to 10 milligram. So that is called stair-step protocol, and you find that the time the time to ovulation was significantly shorter. The time to pregnancy was significantly shorter with stair-step protocol. We'll come to the evidence. So this is a study published by Thomas et al. In 2019, where again the stair-step protocol was used, and it was compared with the CC of 150 milligram. And you can see the ovulation rate was 96% versus 88%. And the time for ovulation, again, it was less with the letrozole group, that is 19.5 days compared to 23 days with clomifene citrate. So this is another interesting study from Russia. So here also again the stair-step protocol was followed, and you can see there is a very high increase in the ovulation rate, especially in anovulatory infertility and PCOS. There was the ovulation rate was around almost doubled. So what they recommended was it's an effective and safe approach for ovulation induction. It allows there will be a shortened time of ovulation, greater endometrial thickness without increasing the risk of ovarian hyperstimulation and multiple pregnancies. So stair-step protocol is a novel protocol which can be tried. So again, this is a published paper from for Fertility Sterility 2020, which again supports the use of stair-step protocol. So this paper, which compares stair-step protocol between clomifene citrate and letrozole for ovulation induction, you can see the ovulation rate was very much high. This is again a 22 paper from Iraq. I think it's from Iraq. Again, you can see the ovulation rate was almost 86% versus 72%. Pregnancy rate was also high with the letrozole group. And again, the mean time for ovulation or menstruation to ovulation was also very significantly shorter in the letrozole. So this study again compares various dosage of letrozole regime, and they started with 2.5 milligram. Again, what the studies have shown that the 2.5 milligram, if you starting dose is 2.5 milligram, it may lead to an inferior response. So you need a higher dose. That is what we usually start is 2.5 milligram daily or twice daily, or you can go for a extended duration of letrozole. Or suppose if there is a failed or a non-responding patient, try to redose the letrozole, or you go for a stair-step protocol. So this may shorten the time for ovulation as well as pregnancy. So that's another regime, a single dosage of 20 milligram on day 3. Again, it has helped, but not widely researched or no randomized controlled studies for the high single dose of letrozole. So addition of dexamethasone, definitely addition of 0.5 milligram for 7 days As sometimes some authors have given up to 2 milligram. Definitely it is increased or improved the ovulation as well as the pregnancy rate. So this study published in 2023 also confirms the diagnosis that if you add dexamethasone in case of resistant letrozole resistant polycystic ovarian syndrome, the ovulation rate as well as the clinical pregnancy rate is definitely to improve. So this is a recent meta-analysis published on dexamethasone and clomiphene citrate. Again, what they have showed also, the addition of dexamethasone combined with CC has improved the ovulation of pregnancy in patients with PCOS, and it improved the hormonal levels also. So this is another paper which again supports the usage of dexamethasone. So here what they did was the control trial of combination of letrozole and clomiphene citrate. I have been telling this in the earlier slides. They tried in 70 patients, and what they showed was there was a statistically significant rise in the ovulation rate in the combination group. That is, letrozole was followed by CC and emitter, and there was higher ovulation rate in the combination group. So this is another combination you can try when there is letrozole resistance. Of course, you can combine with gonadotropins. So what are the common adjuvants used in when there is resistance? I have told about dexamethasone. Metformin is another adjuvant you can use. Myoinositol, vitamin D, N-acetylcysteine, melatonin, and chromium picotinate. These are some of the adjuvants which can be used for improving the ovulation rates in letrozole resistance. Metformin, wide studies are there. Definitely, it has shown that when it is combined with clomiphene or letrozole, can cause better ovulation rate, clinical pregnancy rate, as well as less of multiple pregnancy rate. Coming to gonadotropins, you know that it has got an explosive nature. So whenever you switch on to gonadotropins, whenever there is letrozole resistance or clomiphene resistance, your third line or second line of management is either gonadotropins or laparoscopic ovarian failure. So various protocols with gonadotropins, that is, you can go for a step-up protocol, you can go for a step-down protocol, or combination of step-up as well as step-down protocol. So coming to the step-up protocol, you start with 75 units, then step up if there is no response. But the problem is there is an increased risk of OHSS and increased or excessive multifollicular development. And sometimes she may go for an OHSS with no. So again, step-up regime is not recommended usually. Coming to the low-dose regime, you start up with suppose if you have a pen, you can start with 37.5 and increase if there is no follicular development after 7 days. So again, what is the usual method or the protocol preferred by most of us is the chronic low-dose protocol, which was advised by Roy Holmberg. Again, you start with 37.5 units, international units of gonadotropin, and you have to have a proper counseling because your duration of treatment will be more, and at least 14 to 21 days. But you can see that almost 90% had an ovulation, or the target is achieved by 14 days. That is, you get a 14 millimeter follicle on the 14th day if you go for a chronic low-dose protocol. And if it is not developing, the follicles are not developing, you increase by another 50%. That is from 37.5 to 75%. So the most important thing is counseling of the patient, because you may need a larger dose of gonadotropins and longer duration of gonadotropins. So this is the regime, how you follow. So you can see what is the advantage of low-dose gonadotropins is get better pregnancy, the fecundity cycle, the fecundity rate is more. The mono-ovulation or uni-ovulation is very much high with this chronic low-dose protocol. The risk of OHSS and multiple pregnancy is very, very low with chronic low-dose protocol proposed by Dr. Goyal. So there is another protocol, step-down protocol is there. Again, it is against nature. You start with a higher dosage, and if you see a follicle of more than 10 millimeters and all, then decrease the dose by half an hour. But again, is associated with multifollicular development and multiple pregnancies, but not preferred. So the conclusion is actually in PCO in patients with CC resistance and CC failure. Again, whether you are using urinary FSH or recombinant FSH, there is no difference. between HPHMG or HMG also, there is no difference. So you can choose the gonadotropins, weighing the cost and convenience of the patient and the decision to use one or other. So there is not much of difference between using urinary FSH or recombinant FSH or an HMG or an HPHMG. So in women with clomiphene citrate failure or letrozole failure, gonadotropins resulted in more live birth than continued clomiphene citrate without increasing the multiple pregnancy rate. So always when you prescribe gonadotropins, you have to think of cost and availability, expertise to monitor the ovulation. Sometimes you may have to switch on to IVF. Suppose if there is multifollicular development and risk of polycystis and all, definitely if you have the facility for an IVF, doing an IVF, you can switch on to it, switch over to an IVF protocol. Again, intensive ultrasound monitoring is required. Again, low dose gonadotropin protocols which optimize the monofollicular development is preferred. So always you have to have a strict cancellation policy and always explain that to the patient that about the risk of polycystis as well as multiple pregnancy. So this is again that network meta-analysis by Wang et al. You can see what happens with ovulation, live birth rate, and the multiple pregnancy. This is in comparison of FSH, letrozole, and clomiphene. You have a good ovulation rate with letrozole, you have a good live birth rate with letrozole, and you have a low multiple pregnancy rate with letrozole. So the preferred drug is always letrozole. So coming to the last point, that is the laparoscopic ovarian drilling. So as all of you know that you have to go for laparoscopy. That is only as second line management. If your CC fails, if your letrozole fails, you can counsel the patient either for IVF or a laparoscopic ovarian drilling. So all patients are not fit for laparoscopic ovarian drilling. You have to select your patient. You have to counsel them properly. So always remember the rule of 4, like 4 puncture, 4 seconds, 4 millimeters, 40 watts, use a monopolar or a laser, always catch hold of the antimesenteric water, and always saline irrigate and cool the ovarian surface before coming out. So this is how laparoscopic ovarian drilling helps you. And what you have to counsel them is you can have a ovarian failure and periadnexal adhesion after your laparoscopic ovarian drilling. So always you have to counsel, you have to consider the cost, the expertise required for the use of ovulation induction bar, your operative procedure. Again, the risk associated with their operation, and always counsel them about the small risk of lower ovarian reserve and loss of ovarian function. Of course, periadnexal adhesion. So coming to the final point, that is the third line. Whenever all these things fails, you have to counsel, and if there is additional factors like male factor or an age factor or a reserve factor or anything like that, you have to counsel them for IVF. And always you have to segment the IVF. That is, whenever you are choosing the protocol for IVF, always it is ANDAC protocol, and always it is a freeze-all strategy, and later trigger with agonist and a freeze-all embryos and elective single embryo transfer. This is how you compartmentalize IVF protocol in a PCO woman. That is, you go for an ANDAC protocol, you trigger with agonist, selectively freeze all the embryos, and transfer an elective single embryo. Always this, if you follow all these 4 things, definitely your polycystis rate is going to come down. The multiple pregnancy rate is going down. So always remember the algorithm. The first line is always letrozole. You have the option of clomiphene. If fails or if there is resistance, definitely you have the add-ons. And the second line is gonadotropins and laparoscopic ovarian surgery. You have to weigh between those 2 things. If any other factors are there, definitely you can jump into the third line. That is the IVF or the in vitro fertilization and HC. So always when there is a failed induction or failed ovulation induction in PCOS, always go back to your history. Think of some cause which can cause this resistance. Counseling is the cornerstone. Rule out the differential diagnosis as always. Already I have told about the thyroid disorders, hyperprolactinemia. Always stress on the weight loss. Always stress on the diet management as well as exercise. Stick on to that. If they lose at least 5 to 10%, definitely she's going back on the track of ovulation. And always think differently. So if one protocol of letrozole fails, go for another protocol. And don't waste time, especially when there is a another infertility factor also is there. So if there is only sole and ovulatory infertility, you can think of different protocols of letrozole and clomiphene. So to conclude, PCOS is the most common endocrinopathy you come across, and ovulation is a major challenge. And PCOS resistant to an ovulation, you can try different options before resorting to IVF. Extended letrozole and stair-step protocol of letrozole, they look promising. Okay, and always gonad droppings. When you go for gonad droppings, handle with care. And laparoscopic ovarian drilling, always after counseling, and always in selected patients. And of course, we can opt on to IVF as the third and the last option. Thank you. Thank God. Thank you for your patient listening. Thank you.
Yeah. So, Shamima?
Yes.
Shamima, you're
Yes,
there?
Dr.
Yeah.
Yes, yes.
Dr.
Thank you,
Jayalakshmi is
Reggie.
there.
Thank you.
Yeah.
That was an elaborate and very clear presentation. You have told very clearly how to go about each step. Just one question. I just want a common problem we see is when they don't respond to letrozole, and if you know that you told that there is one of the risk factors is free androgen index more than 5. So if you find a free androgen index high or a definite hyperandrogenism, would you like to wait with the anti-androgens for some time, 3 months or 6 months, and then go for ovulation induction with the same again, or you will just go to the next, like for example, step up or clomiphene or addition of metformin like that?
I mean, the problem with the thing is we don't usually go for this free androgen index. That particular study went on with free androgen index. So you know the assessment of testosterone is very tricky. So you have to go for not all the labs are doing properly the testosterone assessment. So you have to go for LCMS. Ideally, what the evidence says is you have to go for a liquid chromatography mass spectroscopy method for assessing the testosterone. It has got a diurnal variation also. But if the patient is clinically hyperandrogenic, you get the signs of hyperandrogenism, definitely you can ask them for the first and foremost thing is weight reduction and strategies like exercise, diet, all
And
those
Dr.
things.
Reggie, they also say that when you do the testosterone, it's a rising level of testosterone that you need to, I think, see.
Okay, ma'am. Again, most of our labs are not standardized.
Yeah, and we don't do. If it is clinically there, then we don't go in for any biochemical testing as such.
Yes, ma'am. Yes, ma'am. And
Yes.
another option
So
again,
I want to bring
not...
out this point actually.
Yeah.
Yes.
Okay. So if the patient can wait and all, definitely you can put them on anti-androgens, telling about the side effects of anti-androgens, especially if you're using cyproterone or something like that. Or you can put them on either drospirenone containing occipils, or you can use cyproterone containing occipils for a few months, and definitely you can stick on to weight loss strategies, and then you can go for your stimulation. You can try if the ovulation, all other things like your the time for the infertility time, how much duration is there, if the age factor is not there, all those things. If time is there, definitely all these tricks can be tried.
Yeah.
There is a question in the chat box, I think.
Yeah. And for this, I think those exercising and all, along with the diet, they don't take, they say we are going to reduce weight and they say we are not going to eat. And that's the worst thing that they do. So, and you have those insulin spikes and all, and that will not let her to reduce the weight also. So I think they should be told that they have to eat the meals on time, like structured like 9 o'clock, then whatever small snack at 11:30, then they have their meal at 2 o'clock, then a small snack, and then the dinner at night. It shouldn't be having a lot of gap between 4 to 5. I think if they work on that, and we just tell them you go and reduce your weight, but they really don't know how to work on it. So we
Just
have to
like a
do a lot of
diabetic mother, they
compliance,
have
and
to have a...
Yes, because it's a visceral fat, and that visceral fat is very harmful with a lot of androgens into it. So I think that is what if we work upon, then we do well with our patients.
Yeah, I think there's a question in the chat box, that is whether you give HCG to trigger ovulation in it. So actually, if you have to time, usually what we do is we go for follicular monitoring, and we call them, and you can time the intercourse, or you can ask them to have, and you can, at least for the first cycle, you can trigger with the HCG whenever there is testosterone and clomiphene. Luteal support, usually we don't give. Suppose if you use gonadotropins, definitely I would like to give the luteal foot support. What about you, Shamima? What about Ritu madam?
Same thing, Reggie. Same thing, Reggie.
Yeah. Yeah, with letrozole and all, we don't give luteal, but yes, with gonadotropins, of course. So I think if there are no other questions, it was a fantastic presentation.
Thank you,
We got a lot of insights, for how to stimulate, and wherever we are stuck up, Dr. Reggie is there with us. And so I think we can end up the session. And I really feel short of words for thanking our mentors, Dr. Ashok Khurana sir, and also Dr. Ratnapuri madam. And we are really missing Dr. Raju Nair. He is not with us, as Kerala chapter with us. And also all our learned speakers done a fantastic job, have done justice to the subject. I think we've gone a lot of way from genetics to ultrasound to monitoring to stimulating. And also we have our, they really shared with us the pearls of knowledge, and our chairpersons, Dr. Deepak Modi, Sir, Dr. Priya, Dr. Ladvans, Dr. Reshmi, Dr. Shamima, and Dr. Jayalakshmi. You've given a lot of valuable inputs, and they've added so much to this session, and we learned, really, I think we learned lots, and made this so lively, so interactive, and all of you gave us your precious time. And above all, also my thanks to the IFS team, Farah and Santosh, who have worked hard with us, and also Conference International, Amit and Karan, who have also given us the unflinching support and made it a flawless conduction. Though we had a little hitches, I'd already logged in, but then some electricity cut off and suddenly I was also cut off. So sometimes it happens. So that keeps going on. But otherwise, it was a very, very fantastic session. And thank you, IFS, for giving us this knowledge sharing platform, and hope we all keep working unitedly. And I think we're going to come up with beautiful, newer inputs and insights. Thank you so much. Deepak sir, thank you, Shamima. Thank you.
Thank you,
Thank you,
Dr.
Dr.
Thank you so much. And
Thank you.
goodbye till we meet again.
Thank you.
Thank you so
Thank you
much.
very much.
Bye, everyone.
Thank
Have a
you.
nice evening.
Thank you. Bye, sir.